We're stepping inside the trauma bay with John Porter, Davidson class of 1981, head of trauma surgery at Cooper University Healthcare, to hear the powerful stories and life-saving lessons that defined his career. We don't often get such a candid behind-the-scenes look at medicine, so please settle in for a great conversation and have your questions ready. John, I'm turning the program over to you.
Well, thank you for the invitation, and I'm honored to talk back at Davidson College. I was gonna wear red and black, but my favorite color now is pink, because I'm a K-pop fan, and my favorite K-pop group is Blackpink, and we can talk about that later. Uh, I just wanted to make one thing clear at the beginning is that a trauma surgeon is different than an emergency medicine physician. Emergency medicine, they're very talented, but they can't do surgery. They handle heart attacks and strokes and all those sorts of things. But when a trauma comes in, they call people like me. My training after I left Davidson was to go to Johns Hopkins and did medical school there, and then did my surgery training there. And Johns Hopkins is very famous for surgery. And I was the first Black person ever to finish surgery training at Johns Hopkins in 1992, and then stayed on there as an attending for 1 year, and then went and did a trauma fellowship at the hospital of the University of Pennsylvania. So from the time I left Davidson to the time I got a paying job instead of a learning job was 12 years. So it took a long time to become a trauma surgeon. There were probably people that graduated with me that were already vice presidents, partners in law firms, and everything by the time I was getting my first paying job as a non-training person. And then I want to start off with one story of is of there was a question already. How can we be more informed and engaged as a trauma patient? So and I like questions. I tell stories, but I also like questions, so don't feel bad about interrupting me. The way to be engaged as a trauma patient and trauma patient family is to not become a trauma patient. And so one of the things that we do at trauma centers, in order to be a certified trauma center, we have to have a prevention program. So we talk about things obviously like seat belts and bike helmets and motorcycle helmets and things such as that, and locking up your gun if you own a gun. But like I said, the gravity is the biggest thing. 42% of our patients now are from falls off of ladders, falls cleaning the gutter, fall when it snows. I know Davidson had a snowstorm. And trauma used to be a young person's game because it was young men doing stupid things. And what they did mostly, whenever the thing that happened before most traumas when young men were involved was the statement, "Here, hold my beer." And then they held the beer and then they would do something stupid. But now, 42% of all of our patients are falls, and about 30 to 40% of the patients are over the age of 65. We actually call that geriatric trauma, but there's one rule in my hospital that the age of a geriatric trauma patient is always 5 years older than me because I refuse to be geriatric. So really, prevention is the thing. And what happens to a lot of old people? They get disoriented in their house. They have loose rugs, etc. One of the common ways that people fall is their bedroom is in the upstairs and they're a little disoriented and they're walking out of their bedroom going to the bathroom and they actually go to the stairs and fall down the stairs. We have that happen probably 3 or 4 times a week. But the main thing is if you become a trauma patient and to be aware is do not rely on artificial intelligence to figure out what we're going to do because every injury is different. And there's probably people on the phone that on the call that know a lot more about artificial intelligence than I do. But the key is the question that you ask the artificial intelligence. So if you fall down the stairs and they tell you you have a broken back and you ask the question to artificial intelligence, what do I need to do for my broken back? The answer that you get's not going to be that good. But if you ask the question and say, what is the best treatment for an L5 transverse process fracture when I'm neurologically intact, then you get a better answer and you can rely on AI. But you might not know to ask that question. So the best way to be informed is to really talk to your doctor. And what a lot of trauma centers have now are nurse practitioners and physician assistants because they don't have to go to the operating room. So if you come in a car crash at 2 o'clock in the morning and then I operate on you, and then I finish that operation, I might not be able to talk to you right away to your family because now there's another person who was in a car crash or fell at 4 o'clock in the morning. So that's why we have nurse practitioners and physician assistants around so that they can actually talk to you and give information and relay that information back to us. I have 37 nurse practitioners working for my trauma service. I only have 12 other doctors. So you can see the nurse practitioners are triple compared to the doctors. And so the story that I was going to tell, and again, I love telling stories and I love questions. The story I was going to tell was how did I become a trauma surgeon and why did I want to do trauma? Well, normally when I get asked that question, the group is a little bit younger than this group, and ask them what happened on November 22nd, 1963. And none of them remember, but some of us will remember. That was when John F. Kennedy was assassinated. I was 4. I was watching Romper Room. And for those who remember Romper Room, it was that kids show and they interrupted. So I was quite upset that they interrupted. I was 4. I ran downstairs, told my mother that they interrupted Romper Room because the president was shot. And my mother told me, stop telling stories, which means that even at age 4, I was already telling stories. Went upstairs, saw everything, watched the funeral and whatnot. But 2 days after the assassination, they were transferring Lee Harvey Oswald from jail to prison, and Jack Ruby shot him on live TV. I saw that. And I told my mother right then at age 4, I was going to grow up to become a person who could take care of the president if he ever got shot. And as the head of trauma at multiple trauma centers in my career, whenever the president travels, the White House medical team actually goes to that hospital ahead of time and you get the president's record and whatnot. You figure out what ICU bed they're going to go into and they protect that, where the press is going to go. And then you're on call if the president ever gets shot. So I have met both Bushes. I have met President Obama, have not met President Trump, although he comes to his golf course in New Jersey many times. So I'm always on call if the president gets shot. So not many people said what they wanted to be when they were age 4 and finally ended up becoming that. So I think that's kind of cool. Another question that I often get is what is the most difficult case that you've ever done? And that becomes two cases, and the first one will show that you have to be ready for the unexpected as a trauma surgeon. And really, that's what makes my life exciting, is because every day is different. I never know what's coming in. When all of you go to the doctor for a problem, the doctor can order multiple tests, ask a lot of questions, and do sorts of things, and then talk to a lot of colleagues and try to figure out what's wrong. I have to make a life and death decision. If somebody has a blood pressure of 70, I need to make a decision within the next 5 minutes or the person's dead. And if I make the wrong decision, then that death could actually be my fault. So I make decisions on limited information, but then have to change the direction of the plan instantly. It's very helpful in trauma when I'm leading meetings that aren't trauma. People get upset at me because I'm ready to make a decision and they want to have another meeting. And so my definition of a good meeting is one that ends with a decision and I don't have to have another meeting because that's what I'm used to in trauma. And so one case, it was a 15-year-old boy who had gotten stabbed in the chest, and we had to, is that John Madden there? I met with Eileen Campbell today, and she told me to tell you hi if you signed on. He wants to
Please,
unmute.
please give her my regards, and I hope you got the photo we sent from our 50th high school reunion.
Yes, I did. Well,
Great.
thanks for signing on. So
No,
this
sorry to be late. My niece Lindsay Perea said to tell you hello.
Yes, she was my fellow, and now she's the fellowship director at a nearby hospital in Philadelphia. And when she came here, she said, "Maybe you played baseball. Maybe you know somebody." And I said, "Oh yeah." So telling stories. So this 15-year-old was in a motorcycle crash and had a lung injury, and we had to open his chest, and we saved him from that, but we couldn't close his chest because he had too much swelling. So we were taking him back to surgery the next day once the swelling was down in his lung. His lung was actually coming out between the rib cage, and we took him back to surgery. Anesthesia had a central line in one of his jugular veins, and it got disconnected, and air got sucked into the jugular vein and into his right atrium, and his heart blew up like a balloon right in front of me in the OR. And I don't know what any of you might say in that situation. And I don't swear really at all, but the only thing that I could say at that particular time was, oh shit. Because I had never seen anything like that before. The heart was blowing up like a balloon. So, and then because it had air in it, it stopped pumping because it was a vapor lock inside the pump. So I said, I don't know what to do. So I took a 3/0 silk suture and put a purse string in the atrium, and then cut a hole in the heart, put a suction device in the heart, sucked the air out until blood started coming out, pulled the suction out, pulled the purse string tight, tied it down. The heart wasn't beating, so I squeezed it really hard and it started beating again. And I literally made that up at the time, and the he lived and did fine. But that's what you have to do sometimes, is just make some stuff up based on physics and what you know and what you have seen. And that was probably one of the most rewarding and weird things, because he was 15 and had a whole life ahead of him to live. The other one was I had trained a person from Puerto Rico who had come up to do a fellowship here. Her plan was she wanted to go back to Puerto Rico, but she ended up liking it here so much, and she was really talented. And whenever I hire somebody, I take call with them for their first 5 nights on call so that I can make sure that they're comfortable and whatnot. And on their first night on call, it was July 4th, and a man got upset with his wife, and he literally tried to decapitate her and took a large knife and slit her throat, which got her trachea, her esophagus, both carotid arteries and one jugular vein, and got a little bit into the anterior part of her one of her cervical vertebrae. So he literally was trying to cut her head off. And so she worked on one side, I worked on the other side, and we fixed the carotid first, and then fixed one jugular vein, tied the other jugular vein off, then re-anastomosed both the esophagus and the trachea, and then put the muscles back together and essentially reattached her head uh, to the rest of her body. And because we sewed the carotids fast enough, she had no neurodeficits. Uh, and clearly, after she lived, when she went to court, she clearly won her divorce hearings. And so those are two of the best cases that are ridiculous in terms of just one, the number of injuries that the person had. Any one of those injuries, a lacerated esophagus, a transected trachea, or one carotid or one jugular, could have killed the person. And to have all of them in the same person and have them live was pretty amazing. But two people had to operate at the same time. One person can't fix both carotids fast enough because the person then would have a stroke from lack of blood flow. Was there a chat that I saw or no? Okay, because I see chat one down there. Maybe that one didn't get disappeared. That was the question
I only
from
see the
before.
one that you've already answered, John.
Okay. And so I love questions. So the other question that I get, I'm just answering the questions I get from other people since no one's asking questions yet. The other question that I get is, how do you deal with death? Because there's dermatologists and other type of doctors, maybe pediatricians, uh, excellent doctors, of course, but they don't see a lot of death. Literally, we have 6,000 trauma patients a year, and we somebody said, tell me about my interest in K-pop. I will in a second. Um, we have 6,000 trauma patients a year, but we have about 15 to 25 deaths a month because people drive too fast. I'm one of them, and they do stupid stuff, and they argue over at Christmas the Xbox game and then shoot each other. Or they're 70 years old and they climb the ladder to fix the gutters and they fall because they didn't want to ask the grandson to do it. So we have a lot of people that die. And the one thing about death is it does shake you up. But the worst thing is say somebody comes in at 1 o'clock in the morning and you can't save them, and now you're beside yourself and the person died and you're upset and whatnot. Now the person that comes in at 2 o'clock in the morning might have an injury that you can save them from, but now because you're upset over the person that died at 1 o'clock in the morning, you don't save them. So you can't be upset over the death, but you still are a human person, even though some doctors don't act like it. Somebody asked me, how come some doctors are so mean and nasty? Did they learn that in medical school? And I said, no, most of them were mean and nasty before they went to medical school. Um, so the way we handle it is, you look at the situation and was everything done properly? So, did you do the resuscitation right? Did you get the blood flowing fast enough? Did you get the IV in? Did you make the incision in the proper place? Did you send them the CAT scan when they were supposed to? And if you did all the things that you were supposed to do, then you deal with that and say, well, then I'll figure it out later, and then you're ready for the next patient. If when you look at that, you realize that you did something wrong, you then write that down or make a note of it and say, I need to work on that in the future. And now you've corrected the you have a plan to correct the problem. So now you're also ready to take care of the next person. But you can't dwell on the last person. And that's one of the things that's really hard to learn is when you make a mistake, most people tend to dwell on it, but they have time before the next situation comes. We don't have time for that. And sometimes it makes people a little crass, but most of us are actually nice people. And so there were two questions. One was K-pop, but then there was another one that I missed.
Yeah, John, it's how do you deal with making oh, well, actually there's two. I'll do the one that came in first. How do you learn to keep your cool in those dire emergency situations that you've described?
So everybody handles it a different way. I actually have an Aura ring. I've had one since before uh, COVID. There's a question about the pit. I'm actually negotiating with HBO Max and Peacock to actually do a real-time trauma show at Cooper and to compete with the pit. Right now, that's with the attorneys to decide all the HIPAA things about showing people in real time and consent and all that. So I may be on TV, and I'm working with Chanel to see if they'll make me some designer scrubs, but that's a whole nother area of what I do. Because I've gotten into fashion and have actually walked at Paris Fashion Week 2 years ago at one of the shows. But how do we the best way to deal with the attorneys and people wanting to sue is always do the best that you can do and then document that in the chart. Because what people end up getting sued for, so for instance, say you get a fracture and the in the leg, and the leg swells up and the swelling gets so big that it cuts down the blood flow, and now I have to open up the fascia and splay the leg open like a turkey at Thanksgiving. I don't cut turkeys because I tell people when they ask me to cut the turkey because I'm a surgeon, I say I only cut things that bleed. I don't cut dead things. Um, And so that's called the compartment syndrome. And surgeons often get sued with that. And one of the reasons we get sued is we'll write a note in the chart saying the person could have a compartment syndrome. We need to watch them closely. And then 5 hours later, there's no notes been written. And now I'm taking them to surgery for the compartment syndrome, and they sue because we didn't find it fast enough. So the way to do that is if I say I'm going to admit somebody for a compartment syndrome and watch them, I have to have my people, the nurse practitioners, the residents, or myself, write a note every hour to say that the leg is fine. And then 4 hours later, there's a note that says the leg's not fine. I've watched them closely. I take them to surgery. Then there's no lawsuit. So I didn't have to order any extra tests or anything. I just have to document what I'm doing and make sure that I actually did what I'm doing. And so I write down what I'm thinking. So we had a patient that came in today that had air in the wall of his stomach, because we also do all the emergency general surgery. And so typically, if there's air in the wall of the stomach, that means there's bacteria in there, the stomach's ischemic and it might die. But every once in a while, the person is fine with that. And so the young surgeon asked me in the morning, what do you think we should do? And I said, well, if the person's labs are normal and they're non-tender and the vital signs are good, we can watch them. So write down our plan is to watch them because all these things are normal. We're going to check these things every 4 hours. If anything changes, we'll take them to surgery because we're concerned for an ischemic stomach. So now if we take them to surgery in 4 hours and all that's been in the chart, they can sue, but they'll lose. But what the disease didn't change. And so the documentation and obviously knowing what you're doing protects you from the lawsuit. But our practice is not to order a test because somebody might sue or all of that. And so the questions were coming. I remember the K-pop question,
Yeah,
but
and
there was
actually,
another question.
let's go to the K-pop, but not maybe specifically for the K-pop, John, of just in general, when you're in such an intense work environment, what are things that help you? How do you transition from a work day to other interests and hobbies? And maybe K-pop flows into that a little bit.
So trauma surgeons have a high turnover. They move a lot and whatnot. And I'm proud of saying that I've been here for 11 years and no one has left me. I have the same trauma surgeons as I've had. And one of my things is I think that we have fun, and I always talk about fun. And I hope you can tell from the way I'm talking tonight, is I throw a little humor in there even when something's a little serious. And also, my door is always open, so I talk to the people. I've had people come into the office and cry and whatnot. But every day, we sit and talk after we kick the residents and the nurse practitioners out and talk about all the patients that came in the night before, how we dealt with them and whatnot. And sometimes we deal with it with humor. Sometimes there's tears. And then we take care of each other. I work on the holidays so that everybody can have so I always work Christmas and Thanksgiving and New Year so that everybody can be with their family. My kids are grown. And Jason, who'll be 35, is actually older than my youngest doctor, trauma surgeon. So but I'm not old because remember, geriatrics is 5 years older than me, so I will never get old. And then if you call me old, this thing behind me right here, that's my 6-degree black belt certificate in Aikido. So I will hunt you down and flip you. If you've seen a Steven Seagal movie, I trained with Steven Seagal. I've actually thrown him once. He threw me too numerous times, but I have actually thrown him once. And so that by having fun is how we relieve most of it, but also by being nice to each other. So, if somebody does make a mistake, we sort of point it out in a calm way and whatnot, and then I bring them into the office so they can talk about it. I believe that you praise people in public and you give them constructive criticism when the door is shut, when no one else is around. And that has worked out well. And so much so that, like I said, no one has left me. That's technically a lie because one person has left me because I fired him. But I helped him get another job. He sends me Christmas cards, happy birthday wishes. and stays in touch with me, calls me when he has difficult patients and whatnot, because he wasn't a fit for here, but I knew he was going to be a good person somewhere else. So even the person that I fired, and I fired him now 8 years ago, and my birthday was in April. It's not too late to send me a gift. I take a medium in Celine and a size 52 in Chanel. Um, but you have to order special from Chanel because they don't make men's clothes. So all the things I have from Chanel were one of ones made for me. But that's another topic. But that's how we deal with things. And I think fun is overrated. A big topic is burnout, and we talk about it a lot. And I always say, and I argue with my daughter, who is 31, uh, who's a clinical psychologist, and she went to Davis, and we'll both be down there in June because it's her 10th year. But she got to work tonight so that she can start paying bills and I don't have to help her. No, she's very good. And but she's a clinical psychologist and she disagrees with me about burnout, but people don't burn out on stuff they're having fun. And so when a trauma surgeon burns out, what they usually do is move to another trauma center and be a trauma surgeon somewhere else, which means they didn't burn out on trauma. They didn't like that job and they didn't like the boss and they didn't like where they were working. So the people are staying with me because they're having fun. So I emphasize fun, and that's how we deal with things. K-pop came from COVID because during COVID, we thought that trauma would slow down, but people forgot how to act to each other. And at the time, we had one of our busiest years in COVID, and the medical doctors that ran the ICU had to handle all of the COVID people. And we turned that ICU into a COVID ICU, and all of the regular medical stuff, strokes and heart attacks. The trauma surgeons are also surgical intensivists, and we took care of all of that. I had two teams. One team would work 1 week and the other team would have that off, and then the next team would come in and work the whole week. But the only way we could do that was I had to work every day. So during COVID, the initial outbreak of COVID, I worked 183 days in a row, so that we could run the place. But during that time, I'm a huge sports fan, but there were no sports. And the only other thing I would watch was talk shows about sports, but they got canceled too. So I ended up watching K-dramas. And the K-drama was interesting and the music wasn't bad. And so I started listening to K-pop, and then Blackpink had this cute girl named Lisa, and she always wore Celine clothes. And so I bought a Celine shirt that matched my 911 Turbo, and was black and white, took a picture, and I sent it to her. And she actually answered me and said, I like your style. And then one of the other members said, your friend is cute, but I like his car. And she ordered a Porsche, like my car. And so then my daughter Jordan said, oh my God, they're influencers, but you influence them. And then one of them got COVID. Lisa got COVID, and then because she knew I was a doctor, she called me and we talked and we became friends. And then she invited me to a concert and we went shopping together. And now, I'm a K-pop fan. And I was in Paris 2 years ago, Paris Fashion Week, and on a cruise with Chanel on the Seine. And Jenny, one of the K-pop members, was there, and she waved to me and she said, "Hi, John." And I looked around, and she goes, "No, I'm talking to you. You're Lisa's friend." And then all the reporters came over and said, "Who are you?" And I said, "That's not the question. It says, who are you that you don't know who I am?" And I walked away. And so and then I've made one commercial for Celine with clothes, and I was negotiating with Chanel to go to the Met Gala, had everything arranged. They were going to make me an outfit. I was going to do a commercial for the Super Bowl, but Taylor Swift didn't want Chanel in the booth. So I'm not a Taylor Swift fan now because she wouldn't let me do this Chanel commercial. And so, you just can't do trauma. You got to branch out and do some other things and have some fun. So other questions?
Yeah,
Did
there's
I?
one in the chat, John. Do you still perform surgeries daily, or have you stepped back a bit and served more as a mentor and coach to younger doctors?
I run trauma, and I'm also the vice chair of surgery for value and surgical optimization. I'm the medical director of supply chain, so I'm in charge of buying all the medical supplies for the hospital. I'm on the board of a aggregation group or GPO that does all of that. I'm the state trauma medical director. And I do a couple other things. My business card is printed on the front and the back because I have so many titles, but I still do take some call. I take about 10 or 12 calls a year, and on those calls, I still operate. And like I said about the case with the air in the stomach wall, every morning I'm here hearing about all the cases that came in the night before. And as the senior person, not the old person, remember, because I'm never going to be old, the senior person, they ask my opinion and respect it. So I'm still clinical, and they still call me in the OR for the difficult cases because I still know how to operate a little bit.
Um, I,
And
I have another one, John, that somebody sent me directly. What is the single most impactful technological or surgical advancement that you've witnessed in your career?
well, I mean, it's really hard to say uh if there's any radiologists on the phone or you know any radiologists. I will deny having said this, but the CAT scan has changed things because now the person is stable. We can go to CAT scan and see almost all the injuries. So for instance, years ago we would operate on a lot of vessels. We would cut them open, take veins out, take artificial stuff, repair the vessels, do bypasses. And now, if the person's stable, they do a CT angiogram, can see the injury. The vascular surgeons can go in with catheters and fix the person without ever having to cut them fully open. They just go in through the artery and or the vein. So that's clearly a technological advance. Back in the early 90s, when laparoscopy just started, um, I actually wrote the first paper with 510 cases using laparoscopy to go in with cameras and whatnot to do the surgery. And now that's the standard for certain surgeries, uh, and not just trauma, but other things. And then several years ago, they came up with the Da Vinci robot, and we now are one of the first trauma centers to actually use the robot to do surgery on folks. And when I say we use the robot, we actually sit at the console, and then the robot arms, we control them, and then can now one of the problems when you're seeing in surgery inside the body, it's a little dark, your head's blocking the light, you don't have the magnification. The camera on the robot is a 4K camera. So now you're seeing everything like that. There's nothing blocking the light. And then now when you move your hands just a little bit, the robot moves that just a little bit so you can suture and dissect with that. And so in stable trauma patients, because not everybody is dying immediately, but in stable trauma patients, you have time to dock the robot and make little tiny incisions. And now we're sending some of those folks home in 1 or 2 days where they used to stay for a week. So stuff is just changing. So it's really hard to say what the most single advance is, but all of the advances still really depend on a person making a decision. And one of the things that I'm also proud of is I told you I have 12 trauma surgeons and they all have been with me. 8 of them are women. I have the most women working with of any group in the country. Uh, and they're not just women to be token women. The medical director of the ICU is a woman. The associate trauma medical director is a woman. The program director for the fellowship is a woman. There's only one title belongs to a man. All the rest of the titles belong to women.
Great, thanks, John. Let's see a couple more from the chat. How did your involvement in intercollegiate sports help prepare you for your medical career? Somebody knows you must have been an athlete.
Yes, I played baseball. I was All-American the last 2 years that I was there. I batted lead off and could run a lot faster then than I did now. And I played football for 2 years until they beat me up and I decided not to play anymore. Oh, you know, the th it taught it reinforced what my father taught me. My father worked at a factory, a brass factory in the little town that I grew up in. And he worked the same job for 60 years and never missed a day of work. And so he taught me about showing up and doing what you're supposed to do. And then sports builds on that, especially baseball, because baseball is about consistency. You know, we played a lot of games, and then you still had to go to class and you had to time management and do all those sorts of things. And that just made, I mean, medical school was easy compared to Davidson and playing baseball. All I had to do was go to class. I mean, you know, at Davidson, I had to go to class, I had to play baseball, I had to go to lab. And football, all the labs were on Monday afternoon, and so we practiced at night. And so school always came first, but you always had time management things, and that's one of the hardest things to manage when you get to be a busy trauma surgeon is time management. I mean, it's busy to be a mom and time management too, but I'm speaking as a trauma surgeon, not as a mom. So I just don't want to make anybody upset or thinking that trauma surgeon is the hardest thing in the world, because dealing with kids that don't want to listen to you is much harder than dealing with patients who are bleeding. I can stop bleeding. I can't make kids listen to me. Other questions?
Yeah, let's see. How do you deal with health insurance challenges in an acute care emergency setting when the patient needs immediate attention?
Oh, that's easy. I don't pay attention to it. I'd save their life. I don't ask them what their insurance is. So the thing that I'm very proud of is every hospital that I work at, and if you look at their medical record and whatnot, or their card or hospital card, it tells you what the insurance code is. I've never learned what anybody's insurance code is. I just take care of them. And then we figure out how who's going to pay us and if they pay us after. And if they need 5 operations, they need 6 MRIs and 5 CAT scans, we just order it. The nice thing about trauma is we don't have pre-approval. I mean, if I had to call the insurance company to get permission before I operate on somebody, everybody would be dead. So that's the nice thing about being a trauma surgeon, is we just take care of them. And then the beauty of that is we're on salary. So if we operate on people, we don't operate on people, we're paid to be available. So call us 24 hours. So there's a trauma surgeon in the hospital right now, and they'll be here all night. There's a backup person who's at home and has to respond within 30 minutes if the surgeon who's on call calls them. And if the backup person doesn't answer, then they call me, and then I would have to come in. They don't like that. So the number of times that the backup person hasn't answered has been 0, because they don't want to make me have to come in. But sometimes I'm the backup person that has to come in. Uh, and we just take care of people. And so we don't get paid for each operation. We just get paid to be available. And I'm not saying that we're poor, but I'm just saying I don't need to operate on people to make money. And so I don't do pre-approval. I don't check insurance. It doesn't matter if you can pay. We just take care of you.
Great, thanks. What about in the trauma bay, decisions happen in seconds? How much of your work is strict protocol versus a gut feeling that you
Well,
don't?
the thing that I have is I like to have folks that can think on their feet. And I remember a quote from Ralph Waldo Emerson, who said that protocols and guidelines are the hobgoblins of feeble minds. And any day that you can say hobgoblins is a good day, so today has become a good day. And so the protocols and stuff are to guide the people who aren't as experienced. I want people who are experienced and know the protocols and know when to break them. Because the case I told you about at the beginning, when the air started blowing up in the person's right atrium, there's no protocol for that. And so sometimes you have to follow the protocols, and we have set algorithms that we use, but we have to know when to break them. And that's what an experienced trauma center and trauma surgeon will do, is know when to break the protocol. But yes, we do know a lot of protocols, but we write some of the protocols. So 10 years ago in September, we used whole blood for the first time again. And then we wrote a paper and showed that if you used whole blood in trauma patients, you have a 47% greater chance of survival. So now all the trauma centers are using whole blood. But when we started to do that, there was no protocol and there wasn't even a study. But what some people said, which I said, was that when a person is bleeding, they're bleeding whole blood. So why should I give them component blood back, platelets and packed cells and plasma, or why should I give them crystalloid and saline and lactated ringers? They're not bleeding that, they're bleeding whole blood. And we started doing that, and now it's become the standard. So all the protocol started with people thinking first. So I like to have people who are thinking. And to be honest with you, that's what I always tell people that Davison taught me many things, but one of the things that it taught me was how to think. And a lot of people don't know how to think. And trauma surgeons do a lot of thinking. I think there was another one that just popped up, but I was talking,
Yeah,
I didn't see it.
you're right. Did you come across any challenges as a minority individual in med school or training, and how did you respond and or overcome them?
Well, the best way that chose to overcome them was by being very good. And I don't say that to be bragging, but I just did the best that I could. And like I said, I became the first Black person to finish surgery training in the history of Hopkins. Back when I was a medical student at Hopkins, Hopkins still had what's called a pyramid. So they would hire 12 interns, and at the end of the second year, they would fire 9 of them and keep 3 people and let them finish the training and become the chief resident and graduate. And every Black person that they picked prior to me would get cut. And it was part of the contract. You could be cut for no reason. Obviously, if you suck, you should be cut. But if you were good, you were still cut. So there was a new chairman, Dr. Cameron. It was his first year, and he and I had a good relationship because he was a sports fan and he liked me. And I told him, I'm not going to rank you to come here unless you get rid of the pyramid, because you can fire me if I'm bad, but you can't fire me because I'm Black. And he said, that's reasonable. And he got rid of the pyramid. So I did a good job and I finished. So you have to do a good job. Sometimes you have to do a better job. But I remember being in the operating room with the scrub tech was Black, the circulating nurse was Black, the anesthesiologist was Black, and the surgeon was white, and a nurse came in to give the other nurse a break. And he said, you travel a lot. Where's your next travel? And it was just a simple question. And she said, oh, I'm going to South Africa. And you know what he said? He said, well, when you come back, bring a whites only sign. I had to finish the operation. I mean, the patient didn't care that somebody had just insulted me. The patient wanted a good operation. And so I couldn't say anything and whatnot and have an argument with the person. I talked to him afterwards. I'm saying, that's not appropriate. You're my boss and whatnot, but you can't say that. And then and I reported him, and his defense was that he and I had played basketball together and that we were friends and that he was probably joking. And then, of course, the people believed that even though he was lying. But the point was, I couldn't make a stand in the operating room. The patient came first. So there were a lot of situations that I was in like that. And another one is I had a job in Arizona and Tucson, and it's very hot in Tucson, like 120 sometimes hot. And so I was on my way home, leaving the hospital. I was in short pants and casual, and I got a page from the nurse, and the nurse said I hadn't come to, the mother was upset that she hadn't had a chance to thank me. Her son had been stabbed in the chest, and I opened up his chest in the trauma bay, took the knife out, sewed up the hole, and he lived, and she wanted to thank me. And so I said, yeah, I'll come back in. And I walked in like that. And when she saw me, she said, oh, I'm glad you're here. The garbage needs to be taken out. And so I took the garbage out and walked out. And she said the doctor never came, and he said, oh, he came in, and she felt so bad, but I never went back and talked to her. But I still, and then there was another case in Arizona. There was a white supremacy group, and the person was protecting the leader, and there was an FBI shootout, and he got shot in the abdomen with a high-powered rifle and blasted his liver. And on his abdomen, he had a tattoo that said, "I hate black people." But I still opened him up and saved him. Now, granted, my incision was really large, and so his tattoo was removed when I did the incision. But I needed a big incision. It was his liver was injured.
I have one last question that someone sent me directly, and then we're going to wrap up in about 5 minutes. So, as John's answering this question, if you have others, go ahead and stick them in the chat. Maybe we'll have time to get to one more. John, how do you approach the impossible conversation with a family when a trauma hasn't gone well?
Well, the one thing that I want to make people think of two things. One is that the person had no pain. And the other one is that we tried to do everything that we could. And so I usually start off by saying, he came in and he was bleeding, and we did this and we did this, and we tried to stop the bleeding. We got him to surgery as quick as possible. And when the story starts like that, they know that it's not ending well. And so then they will usually interrupt me and said, "Oh, did he make it?" And I'll say he didn't feel any pain. He was unconscious when he came here. And he was unconscious through all the time that we did the work, but unfortunately, we couldn't get his heart beating again, and he passed away. And we actually have chaplains on the trauma service that work 24 hours. So then the chaplain is there. Then there's a nurse with me as well, and then answer any other questions. You hug people if they want to be hugged. You leave them alone if they want to be left alone. But there's no way to sugarcoat that. It's somebody's, and the thing about cancer and other things is you get to do Google searches, pick your hospital, pick your doctor, and prepare your family for all the things and all of that. In trauma, you may have had an argument with your loved one in the morning, or you may have had a nice morning. But no one ever planned on having a car accident. No one ever planned on falling off the ladder and all of those things. And so you have to be direct when you say it, but you try to make sure that they know that the patient didn't suffer and that you did the best that you could.
All right, as we sort of close out, John, could you just, and this is sort of from my perspective as a Davidson College staff member, what advice would you give to a Davidson College student or another young person who's considering medicine as a
Well,
profession?
I would tell them to make sure they're considering it for the right reasons. Because if they're considering it because they think a doctor's cool, if they're considering it because they think a doctor makes a lot of money, or things like that, then they won't be able to do the hard work that's necessary to get the job done and to do all the things that you need to do. So you have to have the right reason that you want to do it. And if you have the right reason that you want to do it, and you're willing to do the hard work, then it can be fun. Because even if you're a dermatologist and you never go into the hospital and you got a private practice and everybody pays you cash and you make $10 million a year, you're still working hard. And if you're working hard, you need to be having fun. And then it makes the hard work less hard. And so you always have to have fun. And you can have fun if you pick it for the right reason. And if you don't pick it for the right reason, then you're going to hate it. And that's true for whether you want to be a banker or attorney or an AI expert or K-pop influencer. You got to have fun.
Great. Thank you so much, John. Your
We're done
story.
already?
Yeah, we are close. You have some parting words, or one more story to tell us. We're about to the end, ready to wrap up.
Oh, well, I mean, um, my one of the things I truly love is Star Wars, and I've written a Star Wars book, and my other love is Chinese philosophy. So my Star Wars book is The Tao of Star Wars, published in 2003. You don't have to buy it. at all. Please don't buy it because I said it. But I use Star Wars characters to explain Eastern philosophy. And the coolest compliment that I've ever received, I sent it to a Chinese um, um, educator at the University of Hawaii and asked him to review my book. And he said that the kanji that I put in the book were the worst kanji that he'd ever seen in his entire life. But he said my chapter on death and understanding death was the best that he had ever seen. And he translated the original bamboo scrolls of the Tao Te Ching into English. And he said that my chapter on death was the best that he's ever seen. And he asked if he could use it in his class. And every year on Amazon in September and in January, there's a little blip in the number of sales of my book because people are using it in their class. And then the second best compliment was, for some reason, the Russians loved my book. Don't ask me why. And so the publishers published it in Russian. And when they published it in Russian, they asked George Lucas to write on the back flap of my book. And he wrote on the back flap of my book, he said, Dr. Porter understands the Force the way I meant the Force to be understood.
Amazing. And as I'm looking at all these messages, John, in the chat, you have clearly made the class of 1981 very proud.
Well, thank you.
Yes, and they're grateful for you sharing your stories and experiences and for the work that you do.
I'm glad some friendly faces came and
Yes.
kept their cameras on so I could see them.
That's right.
So I
That's right.
appreciate that.
And just so participants know, a follow-up email will be sent tomorrow, which will contain John's contact information and also a short survey. And this event has also been recorded and will be posted on our back to school website in the next few days. So if you want to go back and take a listen or share it with someone else, we'd love for you to do that. John, again, thank you so much for taking the time and sharing your fabulous stories and keeping us all entertained this evening. And thanks to all of you all alums for joining us this evening.
It's been my pleasure. Please email me, stay in touch. Jordan and I will be down in Davidson the first week in June for the reunion. I don't even know what clothes I'm wearing, but we'll see.
We'll look forward to seeing your outfit for sure.
Well, thank you again for inviting me. Thanks to all who paid attention and hope you enjoyed it because I certainly did. And have a good night.
Yeah, thanks for your time, John. Have a good night, everybody.